There are women who have spontaneous orgasms completely out of nowhere, men who get flu symptoms and fall into depression after every single orgasm, and people whose genitals won't stop sending arousal signals even when they feel absolutely no desire whatsoever. You probably think I'm joking. I'm not. These are real, documented medical syndromes, recognized by sexual medicine specialists around the world. And most doctors, including most sex therapists, have never heard of them. Today, I'm breaking down the most bizarre and mysterious sexual disorders that actually exist according to science. What causes them, what happens in the body, and what to do if you think you might have one. Let's start with one that sounds like a bad joke, but is absolutely real. It's called persistent genital arousal disorder, PGAD, also known as restless genital syndrome in women. Imagine your genitals are constantly sending signals that feel like arousal. Intense, uncomfortable, sometimes painful, without any sexual desire, without any fantasy, without any attraction to anyone or anything. You didn't ask for it. You're not turned on. You're sitting at your desk, in a meeting, at dinner with your family, and your body is behaving like it's in the middle of a sexual experience. The only relief comes from physical stimulation to the point of orgasm. And even then, the sensation comes back hours or minutes later. This is not a fantasy. This is not a lifestyle choice. This is a neurological malfunction. The nerve signals responsible for genital sensation are misfiring, sending arousal information to the brain when no arousal stimulus is present. Think of it like a phantom pain, but in reverse. Your brain receives a signal. The signal is real, but the source of that signal is a glitch in the nervous system, not an actual external stimulus. The causes are not fully understood. There may be vascular involvement. Varicose veins around the uterus have been found in some patients. There may be nerve compression at the level of the pudendal nerve. And here is one of the strangest findings in the literature. This syndrome can appear when a person starts an antidepressant, and in some cases it can also appear when they stop one. And in some patients, switching to a different antidepressant makes it disappear entirely. Mysterious? Absolutely, but real and deeply distressing. If this sounds familiar, the most important thing I want you to hear is this: you are not broken, you are not strange, and you should not be embarrassed to consult a doctor. There are specialists in sexual medicine who know this condition and know how to treat it. Now let's talk about one that primarily affects men. It's called Post Orgasmic Illness Syndrome, POIS. Every single time a man with POIS has an orgasm, whether through sex or masturbation, his body responds as if he has been hit by a flu virus: headache, nasal congestion, chills, extreme fatigue, muscle weakness, and alongside the physical symptoms, intense mental fog, irritability, depression, an overwhelming need to be completely alone. This lasts anywhere from 2 to 7 days. Imagine what this does to a relationship. Your partner has no idea that what they're witnessing is a medical syndrome. They see someone who every single time after sex becomes withdrawn, sad, unresponsive. The conclusion most people jump to is obvious and wrong. It's not emotional, it's physiological. The current leading hypothesis in the research is that POIS may involve a kind of allergic hypersensitivity to the man's own seminal fluid. And yes, I understand how strange that sounds. Being allergic to something your own body produces, but the evidence supports it. Studies have shown that a subset of POIS patients produce a specific immune response to their own semen proteins. And crucially, antihistamines, the same medication you would take for seasonal allergies, significantly reduce symptoms in many patients. There is also a serotonergic component. Medications that modulate serotonin have helped some patients, which suggests the syndrome is not purely immunological. The nervous system and neurochemistry are also involved. POIS is almost certainly underdiagnosed. Many men with this condition never report it because they are embarrassed or because they assume no doctor would take it seriously. They normalize something that should never be normalized. If you recognize this pattern, consistent flu-like symptoms and mood collapse after orgasm, please speak with a specialist. This is a legitimate medical condition with real treatment options. Let's move to something even more counterintuitive: the hard flaccid syndrome. The name describes it almost perfectly. The penis is not erect, but it is not fully flaccid either. It is stuck somewhere in between, harder than a normal resting state, without achieving full erection. Partially engorged, often retracted, and associated with a range of symptoms including numbness, reduced sensitivity, and in some cases, significant pain. Men with hard flaccid syndrome frequently describe feeling like they have lost control of their own genitals. The dysfunction often appears after physical trauma to the pelvic area, a fall onto a bicycle frame, a hit during contact sports, compression of the perineum. In some cases, it emerges following a psychological crisis without any clear physical injury. This suggests that the pelvic floor nerves, the network responsible for translating nervous system signals into genital response, have been disrupted in some way. The nervous system is sending partial instructions. The system responds partially, and then it freezes. The treatment is as unusual as the condition. One of the interventions that produces the best results is, paradoxically, inducing a full erection, which can reset the neurological sequence and allow the penis to return to a normal resting state. Pelvic floor work, not simply contracting and relaxing the muscles, but re-educating the neuromuscular conduction pathway, is central to most treatment protocols. Anxiety management is also critical because the psychological impact of this syndrome is significant and tends to perpetuate the physiological dysfunction. This is one of the syndromes that very few general practitioners know exists. If you suspect you have it, you need to find a physician specialized in sexual medicine and pelvic neurology. Now let's talk about something that most people have never considered possible: orgasmic convulsions. During orgasm, at the moment of peak neurological arousal, some people experience convulsions, shaking, eyes rolling back, loss of consciousness, in some cases, full seizure-like episodes that are indistinguishable from epileptic events. There are two primary mechanisms behind this. The first is epilepsy triggered by intense emotional and sensory stimulation. There is a subset of epileptic patients whose seizures are specifically triggered by extreme emotional states: grief, terror, euphoria. Orgasm is one of the most intense neurological events the human body produces. The brain generates an extraordinary electrical discharge. For someone with seizure sensitivity in this range, that discharge can cross a threshold. The second mechanism requires no prior epilepsy diagnosis at all. During sexual arousal, breathing accelerates. In the moments approaching orgasm, many people breathe fast, shallow, and through the mouth. This causes a significant drop in carbon dioxide in the blood, hypocapnia, which shifts the acid-base balance of the body. The result is respiratory alkalosis, and one of the documented consequences of acute respiratory alkalosis is muscle tetany and convulsions. In other words, for some people, the way they breathe during sex is enough to cause what looks like a seizure. No neurological disorder required. If this has happened to you or to a partner, and it happens repeatedly, this is not something to normalize. Consult a neurologist and a sexual medicine specialist. A single episode of intense physical response during orgasm can have a physiological explanation. Repeated episodes need evaluation. There is also the inverse phenomenon, orgasmic apnea. Some individuals find that completely stopping their breathing in the final seconds before orgasm actually facilitates and intensifies it. The breath holds, the body goes still, and the orgasm releases. This is not dangerous in a healthy person in small durations, but it is a fascinating example of how closely breath, nervous system, and sexual function are connected. And now the one that genuinely surprises everyone: spontaneous orgasm syndrome. No touch, no stimulation, no desire, no fantasy. You are simply existing, walking down the street, sitting in a chair, working, and an orgasm occurs. I want to be precise about what this is and what it is not. An occasional sensation of intense pelvic warmth or a fleeting pleasurable pulse is not what we are talking about. We are talking about a full orgasmic response, involuntary, unprompted, unwanted. Documented cases have appeared in two contexts. First, pharmacological. A specific antidepressant called trazodone has been associated with spontaneous orgasm as a side effect. This is not a minor detail in the literature. It has been documented in enough patients to be recognized as a known adverse effect of the medication. Second, neurological disease. In conditions affecting the spinal cord or peripheral nerves, multiple sclerosis, certain neuropathies, compressive lesions, the nerve pathways that carry genital sensation to the brain can malfunction. They fire when they should not. They send pleasure signals with no input. In these patients, spontaneous orgasm is sometimes one of the first symptoms of an underlying neurological condition, appearing before any other neurological sign. A single spontaneous orgasmic sensation? Probably not concerning. Repeated, frequent, progressive spontaneous orgasms? This needs neurological evaluation without delay. Now, I want to give you the perspective that I think makes all of this make sense. Every single one of these syndromes seems bizarre on the surface. They seem like exceptions, curiosities, things that couldn't really happen. But what they all have in common is this: they reveal exactly how sexuality actually works in the human body. Sexuality is not simply desire. It is not just psychology. It is not just anatomy. It is the result of a simultaneous interaction between the nervous system, the vascular system, the endocrine system, the immune system, neurotransmitters, hormones, and emotional state, all operating in concert, all influencing each other in real time. When one piece of that system misfires, a nerve pathway that sends the wrong signal, a hormone that tips into the wrong range, a neurotransmitter that surges at the wrong moment, the entire system can produce something that looks impossible. The reason these syndromes matter beyond the patients who have them is that they teach us something fundamental. The body is extraordinarily complex, and sexual function, which we tend to reduce to desire and performance, is one of the most elaborate expressions of that complexity. If you experience any of what I described today, don't self-diagnose, don't normalize, don't be embarrassed. Consult a specialist in sexual medicine. These conditions have names, they have research behind them, and they have treatment options. And if someone you love is experiencing something that looks inexplicable, that looks like withdrawal or physical illness after intimacy or uncontrolled physical responses, consider that there may be a physiological explanation before assuming an emotional or relational one. I'm Dr. Maya Roa. Your body is more complex than anyone has told you. That's worth understanding. And if you want to understand another condition that affects 1 in 10 women and is still massively underdiagnosed, my last video on polycystic ovary syndrome is linked right here. Everything your doctor probably didn't explain. Go watch it.